Welcome. I'm Diane Lavinia, Director of Industry Relations for the IDSA Foundation. Thank you for joining us today for From Awareness to Action, utilizing the latest diagnostics to eliminate hepatitis C, a non-CME program of our Dr. John G. Bartlett Memorial Education Series. And special thanks to our webinar sponsor, Roche Diagnostics. Before we get started, a few housekeeping matters. This webinar is being recorded and will be available on demand if you can't stay for the entire presentation. A link will be emailed to all registrants within 3 business days, or you can access it and share it via our website and the IDSA Foundation YouTube channel. You'll notice that your microphones are muted, but please use the Q&A feature to ask questions during the event. There will be a dedicated Q&A session at the end of both presentations. If we can't get to all the questions during the live event, we'll do our best to address them in a follow-up email. Now let's begin by reviewing the learning objectives. Our presenters will review the following: examine the current trends in HCV testing and treatment and analyze the low cure rates within the US compared to other countries. Examine the challenges of accessing HCV testing and linkage to care. Discuss the role of HCV confirmatory solutions such as HCV RNA, HCV genotype, and HCV antigen in patient management. Examine the importance of screening and testing for viral hepatitis and explore barriers to accessing tests and treatment, including stigma, affordability, and mobility. Review the critical role of primary care providers in HCV elimination. Address the available treatment options, and review the updated treatment guidelines. And with that, it's my pleasure to introduce Dr. Tony Martinez. Dr. Martinez cares for patients with liver disease and addiction disorders, including opiate dependency, viral hepatitis, alcoholic and fatty liver disease, at Erie County Medical Center, where he is the medical director of hepatology. His clinic, La Bodega, has been recognized nationally and internationally as a novel co-localized model for managing viral hepatitis and addiction disorders. Dr. Martinez has lectured worldwide on Hep C management among people with substance abuse disorders. His team's work has presented at the annual liver meeting of the American Association for the Study of Liver Diseases, the annual conference of the International Network on Viral Hepatitis in Substance Users, and at the International Liver Congress. His research involves improving Hep C treatment in populations disproportionately affected by HCV, particularly people who inject drugs. He has been a primary and co-investigator on numerous clinical trials related to Hep C and fatty liver disease, and he is board certified by the ABIM and the American Academy of HIV Medicine. A fierce advocate, he works to eliminate Hep C treatment restrictions throughout the US and Europe. Dr. Martinez, it's an honor to have you.
Thank you. Thank you all very much for joining us today. I think these guys are queuing up my slides here. So you can go to the next slide. This is what we're going to talk about today. Here's my requisite disclosures, and let's get right into it. You can go to the next slide. So I think, as most of you are aware, the World Health Organization has an elimination target for hepatitis C, and the goal is to eliminate it by the year 2030. Now, to do that, we'd have to achieve 4 key things. The first is that we'd have to reduce new Hep C infections by 80%. That, sadly, in the United States is not the case. New infections are outpacing the number of people who are coming into care. We'd have to reduce Hep C-related death by 65%. That's a target that we actually have hit, but I don't think that it's because we're doing anything that amazing. I think it's because we've seen this shift in the demographic, and folks who have Hep C now tend to be younger, and they simply haven't had it for as long as some of past cohorts, like the baby boomers, for example. But suffice to say, that is a target that we've actually hit. We'd have to diagnose 90% of all the Hep C chronically infected population. As we're going to see, we are not even close to that. And we'd have to treat 80% of all of those who we've diagnosed. And I'll show you where we stand in terms of these targets. Next slide, please. So as of now, we've missed 3 out of the 4 targets. And in the US, only 1 in 3 individuals overall has been cured. Now, the numbers actually get worse. It goes down to 1 in 4 if you lack health insurance. If you're in this key age cohort of individuals who are under age 40, the cure rates are only 1 in 4. If you're under 40 without insurance, it's 1 in 6. Now, this is actually the base of the epidemic today. We still have a huge disease burden within the baby boomer population. We have a lot of states where restrictions had been in place, where maybe folks have slipped through the cracks and haven't yet been treated. But this under age 40 group is really the base of the epidemic in 2023, not only because they're chronically infected, but this is actually the population that is more likely to spread the infection. And a lot of this is related to injection drug use. Next slide, please. So there's some key pillars for Hep C elimination. And there's really, I build this around these 4 key things, and it's screening, linkage, treatment initiation, and then harm reduction. Harm reduction really here is synonymous with reinfection prevention. And the goal is to hit 100% in the first 3 pillars and keep that 4th pillar as low as we can. Now, these look different everywhere you go. How we achieve 100% in each of those first 3 really depends on the populations that we're trying to get to and where they may be located. So recently, there's an announcement of a federal initiative for Hep C elimination, and this might look a little bit different in each state. Even within my own state in New York, each of these 4 things, looks very different based on region. So really, this is going to take a mix and match approach. Next slide. So the ultimate goal is to reach a test and treat model of care. Simply put, this means that you come in, we diagnose you rapidly, and we initiate treatment at the same time. Now, to do that, we need better screening tests. So as we're going to see in a minute, that process takes a bit of a long time. And ideally, what we would have is a single point of care test, whether it's a finger stick test or an oral swab, that can rapidly diagnose chronicity, not just an antibody, but a viral load. We need to eliminate all prior authorizations and restrictions. Here in New York, we're a green light state. We don't have any of the above. And this has allowed us to enable a test and treat model of care. We also need a nomenclature change. We really need to get away from differentiating between acute and chronic infection and kind of move things toward being viremic. Conventionally, we wait 6 months to determine acuity versus chronicity. And in that time period, there's not only a delay and a potential loss of that individual to follow up, but there's also the risk of spread. So we know that left untreated, 1 young active injection drug user will infect up to 20 other individuals within the first 3 years of their diagnosis. So we really don't want to wait. We really want to get people diagnosed and treated as quick as we can. And the last thing, that to really enable a test and treat model of care, we need no limitations on retreatment. And that, sadly, in the United States right now is not the case. There's over 25 states that have some language around retreatment of Hep C. Next slide, please. So when we look at some recent data, this came from this year's Global Hepatitis Summit, and it looked at changes in Hep C screening and treatment from 2019 compared to 2021. Now, think about these dates. 2019, we're in the midst of the pandemic. Screening rates plummeted during this period of time. A lot of places where folks traditionally access care, different outpatient programs, for example, in addiction medicine, they closed or they moved to virtual telemedicine. And during this time, a lot of people weren't getting screened. New treatment starts declined almost 75%. We saw, just this absolute bottoming out of Hep C screening and linkage to care. So when we look at 2019 compared to 2021, things look a little bit better. There was about a 24% increase in Hep C screening, and that kind of makes sense. Coming out of the worst of the pandemic, people are coming back into their programs, back into care, screening rates go up. But if you follow this cascade down, there's almost a near equal decline in treatment initiation of those individuals who have started treatment and been cured. So a 24% increase in screening, but a 24% decrease in patients who are starting therapy. Next slide, please. Part of the problem that we have right now is what we utilize for screening. So I think all of you are aware this is technically a two-step process. There's an antibody test. If the antibody is positive, we need a confirmatory viral load. And a lot of times, a lot of different institutions, they don't have the availability of a reflex test. Now, this introduces a huge problem in and of itself. So if we look at reflex testing versus the conventional two-step process, you can see how long it takes from diagnosis to treatment start. So using a conventional antibody followed by an RNA test, that two-step process, it's over a year in terms of the median time from diagnosis to treatment initiation. That's insane when you think about it. That's like diagnosing somebody with gonorrhea and not treating them for a year. If we use a reflex test, the median time is 8 months. So it's improved, but not by a ton. That's not a giant improvement. So this really emphasizes the need for that point of care RNA test. This has been widely used outside of the US. We're hoping that it reaches approval here in the United States sometime within 2024. Next slide, please. Okay, so let's take a look at some of the barriers to screening. We can really break this down into 3 buckets. So on a systemic level, a lot of places where patients are accessing care, thinking about places like addiction medicine, for example, they often don't have phlebotomy on site. Now, that's an inherent problem because then it doesn't matter what screening test you're using if they can't draw blood. And obviously, we don't have the availability of that point of care RNA test. We do have point of care antibody tests, but a lot of sites, they simply don't have the ability to draw blood. Or some sites, for economic reasons or for some other reasons, maybe have not moved to reflex testing. So they're still relying on standalone antibody tests. A lot of times, providers are unaware of the reimbursement process. So using incorrect CPT codes, for example, we hear this a lot in the community around the country. I'm not screening for it because it's not covered. We can't get the test paid for or reimbursed. In most cases, they're using incorrect screening codes or CPT codes. There's also patient-based barriers. A lot of patients simply don't want to be checked. There's still stigma around Hep C. There's fear of being diagnosed. Once they're found to be positive, a lot of patients don't want anybody to know about it. We hear a lot from patients, I've already been checked. They think they may have already been checked. They confuse hepatitis B with hepatitis C and hepatitis A. They may have been checked years and years ago, but they still had ongoing risk factors. So that's something that we hear a lot. And a lot of times patients don't want to be screened because they have poor venous access. They don't like to get blood drawn. They can't get blood conventionally, and they struggle with this. There's also provider-based barriers. Providers still unaware of guidelines. So we see this a lot. The guidelines change. We've moved in the US to near universal screening of all individuals over age 18. Pregnant women at the time of each pregnancy. So we still have a lot of education that needs to be done around what those guideline changes are. A lot of times providers are unsure of what tests to use. So we still see, I can tell you an example. I saw a consult yesterday. The patient has had a Hep C antibody checked literally 20 times in 5 years, and it's positive every single time. So there's kind of more education that needs to be done around the available tests, what to use, what to order. There's still concerns around consent, although in most cases, this is not something that's a thing. This doesn't exist. But we hear this around the country as well. I still need to get consent from a patient in order to be able to screen them for Hep C. And finally, there's this sort of culture of, if I order it, I own it. And this has been a bit of a holdback that we've seen in primary care and even pediatrics and obstetrics, where providers are a little reluctant to screen individuals because they don't necessarily want to treat the Hep C themselves, and they don't maybe have somewhere to send the patient. So these are all things, different barriers related to screening. Next slide, please. There's also some barriers around treatment uptake and linkage to care. And again, these exist on the same 3 levels. So on the systemic level, the system is really hard to navigate for patients and providers. You think about this, patients often don't have transportation. They have trouble navigating the paperwork and all the phone numbers and trying to get the appointment. That can be really, really difficult. Lack of insurance is always an issue. Lack of provision of services. Maybe you're in a rural setting and you don't have anywhere to send patients. And the prior authorization process, once you do get somebody to initiate treatment, can also be really long and cumbersome. There's patient-based barriers as well. Patients, like I said before, stigma is still a huge issue in Hep C. A lot of it has to do with how the virus was acquired. So it's specifically things like substance use. There's still fear of side effects. We still have a lot of individuals out there who saw a relative or a friend or a family member who went through treatment in the old days with interferon. They saw what those side effects look like, and they almost have this interferon-based PTSD where they're afraid to start treatment because of those things that they saw in the old days. There's a lack of Hep C related knowledge or, excuse me, sorry, or perceived need for treatment. Hep C, one of the biggest problems among patients is that it's asymptomatic. So they feel okay. They feel like, why do I need to get treated if I feel fine? There's also, again, provider-based barriers. There's concerns around adherence and reinfection, although the literature has really widely dispelled these sort of misconceptions. Patients are just as likely to be adherent. Reinfection rates are pretty low. The providers a lot of times are uncomfortable managing coexisting mental health or substance use issues, and there's still a lack of Hep C treatment knowledge. Next slide, please. Okay, so really what we're trying to do in terms of the management of Hep C is something called decentralization. So the baseline workup's gotten really easy. The diagnosis of Hep C is getting easier, especially as we move toward point-of-care tests. And all of this enables non-specialists to manage the Hep C. And that ultimately enables decentralization into the community where it's being managed by a multitude of different providers, not just primary care, but addiction medicine, even psychiatry, obstetrics. And hopefully all of this results in increased rates of screening and linkage and ultimately cure. Next slide. So we can manage Hep C in a number of different settings. A lot of what we do depends on the resources that places have and the different provider types. Most Hep C right now is being managed and diagnosed by advanced practice providers. These are nurse practitioners and PAs. Most of the work around Hep C in the United States is being carried out by those types of providers in a number of different settings. But again, it's going to take a mixed and match approach. Next slide, please. So we can rely on conventional referral. That's fine. We've seen some of the barriers. The system's hard to navigate. Transportation's always an issue. It can be improved if we use case managers or peers. Telemedicine is great. We can deliver services to any setting. We can provide specialty care where it might not be available. It does slow down the cascade to a degree, though. In my own clinic, we have a test and treat model of care where we initiate treatment on the same day. During COVID, we moved to telemedicine, and what we're able to do in one day, in one office visit, was taking us up to 90 days. But telemedicine has its advantages, and then there's co-localization, and this is one-stop shopping. All the services are offered under one roof, minimizes loss to follow-up, and really streamlines care. And I think co-localization is really what allows that test and treat model to be carried out. So just a few quick steps that can help increase each phase of the cascade. So when we look at screening, we really need to eliminate standalone antibody testing and at least get to where we're using reflex testing only, but hopefully soon we'll have those true point-of-care tests. EMR prompts are great if you're in your institutions. Build these into your EMRs. They're really helpful, and we all get EMR fatigue, but they actually do work to potentiate screening. For those places where maybe phlebotomy is not available on site, we've seen programs where there's lab field trips where they take multiple patients at one time to a commercial lab like Quest or LabCorp to get their blood work done, or even in the reverse where we've seen phlebotomists come to those clinics and carry out this screening in that manner. Ideally, too, we really need to move to opt-out testing. So a lot of places now it's opt-in. They ask the patients, do you want to be screened for X, Y, and Z? And most of the time, patients say no. Opt-out testing is different in that we're saying, hey, these are the things that we screen for. We do it automatically. It's a bundle of tests. And really, we move away from like, we're just going to check you for HIV or Hep C. We say, look, we're going to check a bunch of different things, one of which is Hep C. Are you good with that? So that really improved. And we've seen the data from the HIV story where that really helps to improve things. Next slide, please. We can improve linkage to care with utilization of peer navigators and case managers. I know in our own program, these individuals are the lifeblood of the program. They work to really reduce your no-show rate. They increase your clinical volume. They make things much easier for patients. Telemedicine, like we said, this is a great facilitator for linkage to care. A lot of work being done in that setting. I really think co-localization of services, like I said, is the key to a test and treat model. And I think flexible scheduling is really important. We know that a lot of these young individuals with Hep C, it might take them 6 touches before they finally link into the clinic. Multiple no-shows for a lot of different reasons. So you really need sort of a flexible dynamic schedule for working them into your program. Next slide. And the final thing is increasing the treatment and adherence step. So one thing that we do in my own clinic, we collect social media handles. We can put those into the EMR. A lot of folks change their cell phone, they change their email, but they tend to manage their social media accounts. So this is a good way if you've lost somebody to follow up that you can maybe bring them back into your program. We partner with pharmacy. We actually have a pharmacy on site right in the clinic where we have meds on the shelf. These individuals are absolutely invaluable. I can't say enough how important they are to the success of your program. We also use a triage system for medication management. So this is a system that's red light, yellow light, green light. It's not that highbrow, but this is a way that we decide if we're going to dispense the patients all the medications up front, so the full 8 or 12 weeks, or if we're going to give it to them a month at a time, or even maybe a week at a time, for example. And then I would highly recommend that you utilize your local databases that might be available to you, whether it's through commercial labs or even statewide. A lot of times patients have had labs done already, even if they're a little bit out of date. You can access this stuff. You have to do a little bit of legwork and a little bit of forensics, but these things may well be available to you. And with that, that's my last slide, and I'll turn it back to our host and over to John.
Thank you, Dr. Martinez. As a reminder to the audience, please use the Q&A button to ask questions at any point during the presentation. Now I'm pleased to introduce you to Dr. John Ward. Dr. Ward directs the Coalition for Global Hepatitis Elimination of the Task Force for Global Health, providing a community of practice for more than 6,000 partners in over 90 countries to collaborate, receive technical assistance, and participate in opportunities for operational research. Globally, Dr. Ward advises hepatitis elimination activities of national governments, WHO, and other organizations. Dr. Ward convened the first United Nations group of friends to eliminate hepatitis. Over a 13-year tenure, Dr. Ward directed the CDC Division of Viral Hepatitis with responsibilities for the first national plan for viral hepatitis prevention, national policies for hepatitis vaccination, HBV and HCV, and testing and outbreak response. Over a 14-year period, Dr. Ward directed national HIV/AIDS surveillance, identified new HIV transmission modes, HIV natural history, and evaluated the first FDA-licensed tests to detect HIV. Dr. Ward has authored over 185 scientific publications of viral hepatitis and HIV. Dr. Ward conceived of and edited Silent Victories, a history of public health in the 20th century, published by Oxford University Press. Dr. Ward is a professor in the Hubert Department of Global Health, Rollins School of Public Health, Emory University in Atlanta. Dr. Ward, welcome, and we are thrilled to hear your presentation.
Oh, thank you very much. I greatly appreciate being part of this webinar series and to hear the excellent remarks from Tony. regarding how to improve access to testing, care, and treatment for people at risk for or living with HCV infection. Next slide, please. These are my disclosures representing the support to the task force for the Coalition for Global Hepatitis Elimination. Next slide. What I'll do is just touch again a bit on the goals for hepatitis C elimination, the role of testing as an essential component of programs seeking to eliminate hepatitis C virus transmission and related morbidity, some of the aspects of the strategies and technologies for testing, and then give you some examples of testing programs in other countries to compare with the state of affairs here in the US. Next slide. I always like to start off my presentations with about hepatitis C elimination regarding recognition of our three colleagues' scientific work that led to the discovery of hepatitis C virus, first reported in 1989, and with their recognition of their being awarded the Nobel Prize in Medicine and Physiology in the year 2020. And I think it's very notable that the Nobel Committee recognized how this discovery had led to the reliable test and the now curative treatments that make elimination of hepatitis C feasible around the world. And I think it's upon us, as clinicians, public health officials, members of the public, policymakers to all come together and make that happen. Next slide. The state of affairs in the U.S., again, Tony touched a little bit on this, but I think it's important to recognize that the U.S. has progressively developed action plans for hepatitis elimination. There's one currently in place. There's recognized about 2.4 million people are living with hepatitis C in the US. There's about almost 70,000 new infections a year. That's a conservative estimate based on the quality of the surveillance data. As I'll show you in a moment, that's increased over time. And as you can see here, about 60% of people, it's estimated, are aware of their infection status. This is part of a national hepatitis elimination profile that we have brought together at the Coalition. It's available at globalhep.org, along with profiles for 30 other countries for comparisons to the US in this particular instance. Next slide, please. Looking back about the progression of policy development for testing, the epidemiologic data 15 to 20 years ago began to point out that we had this bulge, if you will, in the epi curve for hepatitis C that was concentrated in a certain age group, and then that age group would move progressively over time. So we began to refer to it as a birth cohort that aligned very well to the highly well-known baby boomer cohort between 1945 and 1965, whereby about 2 out of every 3 people about 15 years ago were in this baby boomer cohort who were infected with hepatitis C. And our further investigations found that a good proportion of those already had moderate to severe liver disease, contributing to rising mortality over those years, and indeed exceeding deaths from other notifiable diseases to CDC. Next slide. So that was really the evidence that led to the first general population-based testing recommendation for baby boomers, for those born in this birth cohort, for the other reasons shown on the left. That was that we released in 2012. Next slide. In the subsequent years, it was shown that the incidence of hepatitis C, the increase of which began around 2009, 2010, began to accelerate, heavily concentrated among young people, about a 3-fold increase in incidence, so fairly large and alarmingly large increases in new infections. And to begin to capture that population younger than the baby boomer cohort, CDC moved toward a recommendation for all adults receiving, at least on one occasion, a test for HCV infection. And both that baby boomer and now the all adult recommendation was also accepted and endorsed by the U.S. Preventive Services Task Force, making this a no copay preventive service for all patients in primary care in the United States, removing a key financial barrier to testing. Next slide. Along this time, because of the accumulating evidence demonstrating the high cure rates from these all oral therapies for HCV and their excellent safety profile, very few drug-drug interactions, etc. AASLD in coordination and collaboration with IDSA put forward guidelines for all people with evidence of current HCV infection should be treated for HCV in the United States, and that this is now the global recommendation put forward by WHO. So here in the U.S., we have a test all adults, treat all persons with HCV infection. Now, one of the consequences of this large infection in the incidence among young people is high rates of HCV now among women of childbearing age. I find it very alarming that in addition just to the high infection rates among young people in general, the high infection rates here among pregnant women, 1 out of every 215 pregnant women in the U.S. have evidence of HCV infection. And you can see there of women with no prenatal care, it's 1 in 44. That's just an astounding rate to me. And what's equally concerning here is that pregnant women are currently not recommended to receive treatment because of a lack of safety data. The coalition has a registry seeking to collect safety data for pregnant women that do decide to be treated so that we can help with that safety profile. And you can go to our website at globalhealth.org to learn more about that. Next slide. Our toolbox, Tony touched on this, is really robust. This is a systematic review that I was a part of that was authored by Evan Cunningham and our collaborators in Australia and elsewhere to show what's the evidence of strategies that promote access to testing, linkage to care, and treatment. And as you can see there, those that include patient chart reminders, obviously provider educations that increase their awareness and sense of capability to manage HCV infection, the role of mid-level providers such as nurses, but also pharmacists, importance of integrating care with other services, directly observed therapy can have a role, such as in methadone clinics, patient education, so they understand the importance of HCV treatment, and then a variety of testing applications, point of care, anti-HCV, point of care PCR, opt-out testing, reflex testing, and the use of dried blood spots. Next slide, please. As far as testing for HCV antibody as part of this typical two-step process, you obviously have lab-based anti-HCV testing, which is the most prominent here in the United States. The advantages of that is their wide availability, their high quality, and their high throughput so that you can test large numbers of persons. There's also rapid diagnostic tests available that are simple, low cost, particularly outside the United States, and can be used with specimens of serum, plasma, or capillary whole blood here in the US. Also, it can be used on saliva, but that's not licensed by the FDA. That's only available outside the United States, but it does provide a simple and typically very low cost, high quality way of identifying people who have been infected with HCV. Next slide, please. To test for evidence of virus, the PCR is really the standard of care. Again, that's available in laboratories for high quality, high throughput testing, as shown here. Point of care testing has clear advantages. Sometimes that's used in laboratories. Some of that's even mandated by national governments, such as in Europe, in many countries in Europe. or where its big advantage is that it can be there at the point of care, so you can diagnose someone before they leave that clinical setting and begin to provide treatment. Those tend to be, smaller in throughput, but that convenience and immediate availability has distinct advantages. Another option over and above PCR is HCV core antigen testing, which is not yet licensed in the United States. It's a serologic-based test, so it can be used on the serologic platforms being used for other tests, including for antibody. It performs with high sensitivity and high specificity, except for specimens with low viral loads, such as those that are in the early stages of infection, or perhaps in the late stages of viral clearance as they are nearing completion of treatment. Next slide, please. As Tony mentioned, we really want to make sure that we get reflex testing broadly adopted in laboratories or at the point of care. When you have point of care tests for both antibody and PCR available, because that removes one critical step that results in people not getting adequately diagnosed with current infection and into care. And we have ample evidence to show the value of reflex testing. Next slide. As Tony pointed out, it has clear advantages in reducing that interval between detection of HCV antibody, detection of PCR, and then treatment. And so we want to continue to narrow these gaps that result in people falling through and not receiving care. Next slide. One testing application that may be coming into the US soon is what's called a duo test, where there's simultaneous testing for both HCV antibody and HCV antigen. And so that's tested at the same time, so that if antigen is detected, you have immediate recognition that someone is currently infected. However, because of the performance of the duo test, it's recommended that if you have a positive on antibody but negative on antigen, that then proceeds to be tested by PCR to make sure that all current infections are identified. So just be mindful of this. Could be a new option for testing coming up in the near future. Next slide. The other, evidence that we want to be mindful of is that we do have good pilot projects demonstrating the feasibility of elimination in the United States, most notably the HCV elimination program in the medical centers of the U.S. Department of Veteran Affairs, where for many years they have put together a strong program guided by their evidence of high prevalence, particularly among the Vietnam era veterans, then putting in models of care throughout their system, having the data to track the quality of those sites to improve quality with those evidence, putting in care models, and then improving those care models over time with that evidence. And you can see there's been excellent response to that, with the prevalence falling from about 160,000 veterans with HCV to less than 20,000, about 17,000 currently, about a 90% decline. So a true example of what's possible within health systems in the US. Next slide. There's also models for demonstrating the feasibility of providing HCV treatment for people who inject drugs. We were part of this study known as HERO in about 8 sites in the US, where HCV medications were available through a directly observed therapy approach for methadone maintenance, or through an extended directly observed through telemedicine for people with methadone or buprenorphine, showing about a 90% cure rate, even though a high proportion of those persons were continued to inject drugs. Next slide. regrettably, too few people are receiving treatment. Tony touched on this. This is a major issue. Obviously, the benefit of diagnosis is treatment. People aren't receiving treatment. They're not receiving the benefits of their diagnosis. And there's a particular problem for persons on Medicare or the uninsured, or persons in prisons where they do not have the freedom to seek treatment on their own. Next slide. Some of the barriers to treatment after diagnosis are systemic, with these restrictions on authorization for paying for the prescriptions. This is just one example of prior authorizations are still needed in 27 states for a provider to actually call up or contact and get approval by the insurance company or by the Medicaid program, which only increases the hassle factor of busy clinicians to get involved in testing and treatment. This has improved a bit over time, but not sufficient to make this a open access around the country. Next slide. Tony also mentioned there's also issues with a large number of states requiring approvals for treatment of reinfection. Comparing the U.S. state of affairs to globally, about 58 million people living with hepatitis C around the world, 1.5 million new infections, almost 300,000 infections every year. Fortunately, the treatment costs have declined dramatically around the world. Most people live in countries where the cost of a course of treatment is less than $150, even lower if the country is using the Global Fund pricing. So really, since 2015, we've gone from a drug course, HCV drug course costing $96,000 to one costing $60. Next slide. Most of the world continues to be challenged with diagnosis and treatment. So the issues for the U.S. are shared by many countries, and that's one of the objectives of the coalition and other organizations is to improve diagnosis and treatment. And next slide. And we tend to look at testing in the context of an overall program that brings together the essential components to be effective: good data, good policy development, a community mobilization, political commitment, tailoring interventions appropriate for the health systems, a focus on health equity, so all persons in the country benefits from hepatitis prevention, testing, and treatment, financing for the program to be successful to reach elimination goals, and then always having data all along the way to improve what you're doing. Next slide. I want to just give you three examples from other countries of their approaches to testing in the context of an effective HCV elimination program. Next slide. In the case of Egypt, a country that once had the highest prevalence of hepatitis C in the world, they had a national call from their president that all adults be tested for hepatitis C, and with a commitment to mass media health promotion, wide availability of testing at no cost in the community and throughout their health system, an excellent data system to track who was getting tested based on their national identification card, and then if antibody positive, referring that person to a treatment center for PCR testing, and if positive, treatment. As you can, and then all of that also with very favorable costs for that laboratory testing and for treatment. So you can see 75 million people tested, 5 million people treated. Next slide. And they decreased their prevalence from 10% to 0.4%, and are already seeing declines in new infections and in deaths. And they were recently awarded as the first country to reach the gold level status of their progress toward HCV elimination. Next slide. So that's antibody testing followed by referral of the patient. Then you have Rwanda, low-income country in Africa, starting prevalence of 4%. They put in place many of the aspects of a program similar to Egypt: broad access to testing, all adult testing recommendation, a scale up of treatment by education of care providers, and then task shifting to allow non-MDs to prescribe treatment. In this case, they had point of care testing. Then if positive, they drew the blood and then sent the blood to central laboratories for testing and then sent the information back to the clinical site. Next slide, please. Through their efforts, a low-income country, mind you, they believe they've now diagnosed 95% of persons with HCV. They've tested over 6 million, treated over 50,000, and they have now believe their prevalence is less than 1%. Excellent progress by a low-income country. And then lastly, so in this case, a referral of the specimen rather than of the patient. Next slide, please. In the case of Georgia, a middle-income country in Eastern Europe, committed to a national elimination program around 2015, again, with broad education, broad testing policies, and then progressively expanding access to testing by building out the capability of antibody testing and PCR testing throughout their health system, so that all that testing was done as part of routine testing that was being done in their laboratories. They've made excellent progress toward their elimination goals of the number of people diagnosed, treated, and successfully cured through that testing approach in Georgia. Next slide, please. And this just shows you a little bit more success in that program. Next slide. So, sort of somewhat in summary, the U.S. has some aspects of all of these components that make for an effective program. One critical deficit, though, that the U.S. has is a strong national commitment to elimination to begin to link these components together and strengthen them accordingly. Next slide, please. Now, we currently have an effort underway to build that national commitment. Next slide, thank you. It's being led by Francis Collins, the former director of the U.S. NIH, that is part of the Biden administration's priorities for improvements in health here in the U.S. It's part of the Biden presidential budget to requesting about $13 billion over 5 years to bring to the U.S. an FDA-approved point-of-care test for HCV, to provide medications at no patient cost, including those that are on Medicaid, in prisons, or are currently uninsured. Expand various aspects of HCV care capacity, ranging from improvements in surveillance, improvements in health promotion to the public, clinical training, systemic changes, of the type we've been talking about here on this webinar. Next slide, please. Currently, this just gives you a little bit more information about these different aspects of the initiative, including what's called a subscription model, or a Netflix model, whereby, as was proven to be highly effective in Australia, where a state Medicaid program such as Louisiana, Missouri, and Washington is currently embarked on, they buy a set, they purchase at a set amount and unlimited access to HCV medications over a particular period of time, and then they can treat as many people as they can find in that period. What I think is particularly attractive about that approach is the strong motivation for testing and diagnosis, because the more you diagnose, the less you're paying per patient to cure HCV. So this is a very, very prominent part of this initiative. Next slide. And just to say, a bill is expected to be introduced into the U.S. Congress in the very, very near future, with the goal of seeking money in this for FY24 for this 5-year initiative. So please keep your ear out for the news of this this bill being introduced. Next slide, please. So hopefully I've given you some additional information about the status of HCV testing, its importance to achieve goals for hepatitis elimination, and the lessons we can learn from other countries that have put together highly effective programs. And please visit globalhep.org, sign up for our newsletter, and stay up to date about advances in HCV elimination. Thank you.
I'd like to invite Dr. Martinez to come back on screen so we can now move into the Q&A portion of the webinar.
Yeah, John, there's some great questions. I tried to answer some of them in real time in the chat. For the sake of time, I really, one of them that jumped out at me here that came through, once we have the availability of point-of-care RNA testing, what are some thoughts surrounding the need for hepatitis B testing in parallel to make treatment decisions? So whether that's a Hep B point-of-care test or conventional in-lab testing.
Well, it's recommended that the status of the HBV status be known before you begin to treat someone for HCV, because of the suppressive effect of HCV on HBV replication and the concern about reactivation of hepatitis HBV infection. A point of care for HBV would be helpful. It's just recently been introduced globally. But I think the FDA licensure process for HCV would hold promise for getting something that for HBV. The rebounds tend to be at highest risk for someone known to be HBsAg positive. It tends to be, Tony, it'd be good to get your clinical perspective. In my knowledge, it tends to be a fairly rare event. I don't think it should preclude HCV treatment if the HBV testing is not available at point of care, but it is recommended as part of the pre-treatment workup. What's your thoughts?
This is, I think, a really important question that hasn't really, when we've discussed the federal elimination plan, this hasn't really gotten a lot of attention, this specific question. You're right, this is a rare occurrence that hepatitis B has reactivated. It's happened in a handful of cases globally. It's enough that all of the products that are available for Hep C management have this black box warning. It is in the guidelines that all individuals have a hepatitis B and HIV testing when they are getting their baseline workup. The prevalence of co-infection somewhere around 1.5 to 1.7% of Hep B and C. That said, we've never in my clinic had a case of reactivation. And like I said, we utilize a test and treat model, but we do have the lab on site. So individuals in that same office visit are leaving with their medications, but they're also, before they leave, as they leave with the meds, they're stopping at the lab, getting their Hep B test, getting their HIV test. If, for example, somebody, those results come back very quickly, if somebody had a positive surface antigen, we are obviously able to call them quickly, tell them, don't start the Hep C meds. But I think that this is something that as we progress toward Hep C RNA point of care test, this is something that's going to have to come into the conversation. We do have a national new guidelines around hepatitis B screening and immunization. And I think that this is a good point of intersection where that should kind of marry up to it. But I think that's a really important question. We also had a question regarding primary care. What can folks do to help us to diagnose the undiagnosed? And I think the answer is pretty simple. Just keep screening. Screen every individual who comes in, 18 and up. If you see pregnant women, if you're family medicine, screen at the time of each pregnancy. If you do an adolescent, screen them based on risk factors. We might have time to squeeze in one more. How do we get a 3-month supply all at once in your clinic? Is it through grants? No, actually, we in New York State, it's a high Medicaid population. The meds are covered. We know that they're going to get paid for, so that enables us to allocate the meds. So we just kind of run it in real time.
I do know, Tony, that some some state Medicaid programs require 1-month prescriptions, and so
Yeah.
that is a limit to 3-month.
That's right. And that's still most states as of right now, that even if you wanted to get the full 8 or 12-week supply, you're still not quite able.
Mhm.
John, any place left for non-pan-genotypic drugs?
I don't think so. We have good no, absolutely. We have good options. The pangenotypics work, are excellent. So there's really no reason to use anything else.
Yeah, and we have an authorized generic in terms of the 12-week regimen. We're trying to kind of get to this test and treat model and really streamline it. That partly involves eliminating the need for the genotype. And we're able to do that because we have those pan-genotypic regimens. I
Yeah.
think with that, we might be right at the time limit. I'll ask our hosts where we're at.
Yes, we are. We're actually just about out of time. So thank you so much to Drs. Ward and Martinez for your informative presentations. If there are any questions we missed, we will do our best to answer via email. The IDSA certainly appreciates the commitment to Dr. Ward and Martinez to their very important work and for your time today. Thank you to our audience for your attendance and participation in the Q&A session. If you wish to revisit this webinar or share it with others, a recorded session will be made available to you via email and on our website and YouTube channels. This is our last webinar in 2023 of the Dr. John G. Bartlett Memorial Education Series. We invite you to follow us on social media channels to hear about our webinars in 2024. So please be sure to connect with us there. If you are interested in becoming a member of IDSA, please don't hesitate to reach out to us or visit the IDSA website. And finally, we kindly ask you to consider furthering your support of the IDSA Foundation with a personal donation. Your gift plays a pivotal role in advancing our mission of workforce development and making a tangible impact in the field of ID. Thank you again, and have a happy and healthy holiday season and new year.